couple of options, a couple of things that you can try now if you want to use. I mean, pressure pain threshold, I'm quite confident in. I think that is ready for prime time. No reason people can't use this a little bit more often. Certainly has prognostic value, may have some evaluative, so some change over time value. Not as much, but something to consider, and I think it has some value for trying to identify the mechanism of pain. Okay. So there's my method for cold sensitivity. So just in summary here, I find that quantitative sensory testing, yet again, provides another additional component to understanding your patient's pain experience and potential mechanisms there. I think it can provide evidence of either local or global hypersensitivity. Local hypersensitivity really shouldn't be any surprise for the most part. If somebody's recently injured, you'd expect them to be locally hypersensitive. Global hypersensitivity is something a little bit more interesting. There might be something happening there. It can be useful to measure change over time, but did you ever hear about spin and snout? Positive test on a positive result on a highly specific test is useful for ruling a condition in. Never mind. It's probably more useful for ruling change in rather than ruling it out. What I mean by that is if somebody actually changes by 15 newtons, you go, wow, yeah, that looks meaningful. On the other hand, if they change by less than 15 newtons, we're not sure. They may still have changed accordingly. We just didn't quite hit that threshold. Okay, now I'm going to take a second here. I just want to look at the Google moderator, see if there's any new questions that have been added here. Let's go on here. Here, this question's been sitting here for a while. Are there any populations for which quantitative sensory test is not appropriate or not validated? And certainly the answer is yes. I mean, I've only ever worked with working age adults, cognitively intact working age adults, 18 to, well, we've gone above 65 now, but I have no idea how it functions for people under 18. I don't know how it functions for people, say, 75 and older. I doubt it would function that well for people who are not cognitively intact or are somehow impaired, are unable to reliably rate their pain. So yeah, for sure for those folks there. Are you purposely avoiding the terms peripheral versus central sensitization? Sort of. No, I mean, central sensitization is fine, centrally sensitized. I'm finding those words being a little bit overused lately. I'm not sure if there's a better alternative. I've been talking about centrally facilitated now. I don't know if that's any better or not. Peripheral sensitization, in many cases, is normal. Like I said, you might expect somebody to be locally hyperalgesic. That's normal. If they're, on the other hand, if we're seeing things like allodynia, or allodynia, depending on what side of the Atlantic you're on, or things like wind-up pain, which is all getting a little bit different here now. We haven't gotten into that. We probably won't. Then those might be indicators of sort of pathological peripheral sensitization. I think the term peripheral sensitization people often assume as being pathological, but in many cases it's also normal. So I have been sort of intentionally avoiding those terms to avoid that confusion. An easy pain threshold to use in the clinic is the pain-free grip. Oh yes, for lateral elbow pain cases. Do you know if any other tool has been validated for other specific pathologies that we can use easily in the clinic? And I don't, but that is true. Pain-free grip using like a JMAR or something like that, grip strength tester, has been validated for lateral elbow pain. So yeah, absolutely good point. I don't know of any other ones. In long-standing maladaptive pain states, has there been sufficient research to suggest a minimum detectable change? Shoot, I'm not sure in what modality we're talking about on that question. By and large, there was a group of folks who got together about 4 years ago, 6 years ago, a group of bigwigs in clinical measurement. Paul Stratford was one of them on that paper, who kind of came to consensus basically around what minimum important change is on a lot of pain scales. And a simple rule of thumb that they sort of arrived at was that a 20% change or 30% from baseline. So 20% of the overall scale or 30% from baseline is probably accurate to indicate meaningful change. The one thing that I would urge caution on there is that that probably applies more for mid to low level scores. As I've already mentioned, high-level scores at the very extremes, small change is still probably meaningful. But if you go by 30% of baseline, if it's a 100-point scale, you need a 30-point change. That's probably more than you need. So that's my blanket response to that. If you want to maybe repost that question to a specific assessment, feel free to do so. All right, I think I've been